So what am I doing when I analyze a face? So let's take a look at Allison here and really zoom in on her face, okay? The first thing I do is I want to see if she has good symmetry from top to bottom. So I go to the hairline to the brow, and that should be roughly 1/3 of the face. And the brow to the tip of the nose should be about 1/3, and the tip of the nose to the chin should be about 1/3. So she's got really good symmetry from top to bottom. Sometimes people will have a widow's peak, which will make the forehead look a little smaller. So I might not take that widow's peak into consideration with that. I'll also look at hairline as well. On women, women tend to have a more rounded hairline. She's starting to get a little bit of temporal recession on her hairline, which probably is telling me that somebody in her family at some point loses a little bit of hair. So she'd be a good candidate for some PRF treatments for the hair if she identifies her hair as being a problem. She probably never has it. Now I give her a complex. But it's at the very early stages of what we call female pattern alopecia. And a little bit of platelet therapy in there could go a long ways, all right? So she's got good symmetry from top to bottom. Then we're gonna look and see symmetry from right and left. And what we wanna do is we want the corner of the eyes to be about the width of a nose for a Caucasian person. And then that distance should be about the width of the eye. So she's got good symmetry there. And then we want the lateral projection to be about 1/3 of the face. And she's lacking a little bit of lateral projection on there. So if she wanted, if she was complaining about maybe a sunken face or nasolabial folds, or she didn't like her cheeks, cheek filler on her would be a really good thing. Give her a little bit more lateral projection and give her more of those fifths. Remember, we break the face down into fifths, between the eyes, width of the eyes, and lateral projection. And there should be 5 of those across the face. So that's what I'm doing dissecting. The next thing I do is I look and see, do we have any distractions? So what are distractions on a face? Distractions might be like an age spot. She's got a couple of them there. She's got a smidge of melasma up there, maybe some acne scarring. I don't see any of that. But there is a little bit of a distraction right here. She's got a pretty good mental crease right here as well. So maybe if I do some Tox on her, I could turn off the mentalis muscle and help soften that little crease there if that bothers her. Now on the lower face, we break the lower face down into thirds as well. So the distance between the nose and the chin is 1. This should be about 1/3. That should be about 1/3. That should be about 1/3. So she's got a really good thirds on the lower face as well. Okay, so she's got good symmetry. But let's say that as we age, the lips drift down a little bit. What we could do is we could add volume to the top lip, pull that up to make this space right here look less if this was to be a little bit exaggerated. All right, so always look for the thirds there as well. The next thirds I look for is I want the top lip to be about 1/3 of the total lip volume, okay? And if you look at her, it's probably like 40%, okay? That's called the golden ratio, 40%, 1.618, I believe is that ratio. So you want the top lip to be about 1/3 and you want the bottom lip to be about 2/3 of the total lip volume, which that looks good as well. Why does that look good? Because we've given her lip filler, all right? Now, if she was coming in today saying, I want more lip filler, I'd probably talk her out of her because her lower thirds of her face is well balanced, right? We got good thirds up and down. The lip volume looks good, has a good shape. Probably not a good candidate for lip filler yet, but maybe in 6 months, we could maybe do a little bit of filler. So maybe I'll talk her into doing a little cheek filler instead, if that's what she wanted to do. So that's what we're looking for as well. Other distractions we might find is like a nasolabial fold. That's nice and deep, hers is nice and soft, so I'm not too worried about that. Sometimes we'll get marionette lines. I don't see that. And then she maybe just has the very infancy of what we call a pre-gel right there. So if we wanted to, we might be able to soften that up a little bit, but it's so subtle that I don't even see that's a problem right now. Maybe a little Kybella in that fat pad if it were to drift down a little bit. I'll look at the neck as well. Sometimes we'll get some striations across the neck, which she doesn't have too terrible. And then I'll just look and see, is gravity winning the battle? Do we have more of this going on or more of this going on, right? And I would say at this point, gravity is not winning the battle. So overall, she looks pretty good. Quality of the skin looks good. She's got a good glow on her. So I'm not seeing anything like super obnoxious coming out of her. Okay, so that's my quick assessment that I'll do on a patient as far as symmetry, as far as distractions, and seeing things like that. You know, maybe they have a big mole that I want to remove. It's a distraction, or maybe they have some sunspots that we want to like maybe hit with like a broadband light therapy or intense pulse light therapy, get rid of some sunspots, things of that nature. If she doesn't have a glow, I'll recommend some skin treatments like microneedling or maybe a CO2 laser or something like that. All right. So now what we'll do is we'll pretend that she has some problems and how we would fix them. Okay. So we'll start with Tox. What kind of things can I do with Tox to change the way her face expresses, change the way her face sits at resting, things of that nature. So let's look at her real quick and just do a quick analysis of the different muscle groups on her face. So obviously with Tox, about 90% of what you do is eye level up, okay? We've got a frontalis muscle, lift her eyebrows up. So she's got a nice frontalis muscle that goes all the way to the hairline and puts these lines across her face. So obviously we'd like to turn that off with a little bit of Tox. However, what does the frontalis muscle do? It lifts the eyebrows up. Okay, and if we turn that off by itself, what's going to happen? The depressors, and on the face we have the muscles that are depressors are, you have a little bit of the orbicularis oculi right here that pulls down scal. So you can see right there how the orbicularis oculi is pulling down, relax. We also have the corrugator supercilii that pulls down and towards the middle. And then we have the procerus muscle that pulls down. So scal again. So 1, 2, 3, 4, 5 muscles that are pulling down. All right. So if I turn the levitators off without addressing those, this is going to happen. They're going to become dominant. It's like a tug of war. Okay. And then I took all the guys off this side. We're leaving the guys on this side. We're going to pull down. Most people don't like a heavy brow. So what would we do if we wanted to treat the frontalis? Obviously, we're going to inject at least the corrugators and the procerus muscle and the frontalis. So that way, her eyebrows stay in that third. We don't want her eyebrows any higher because that would shorten her forehead, elongate her nose if that were to happen. And so we want to keep those eyebrows where they're at. So we will treat this about equally to what we do the frontalis muscle. Another trick treating the frontalis muscle, some of the toxins spread very well, like Dysport's known to spread. Why does Dysport spread so much? It's because it doesn't have a lot of human albumin in it. Human albumin has been shown to let the tox uptake quicker. All right, and because it doesn't have a lot of albumin, it tends to spread before the muscle takes it up. So with Dysport, I tend to just put it in a few spots across the forehead because I know it's going to spread out significantly from that. Whereas some of the other toxins like Daxxify and Xeomin are very precise toxins, and they tend to not spread very much, usually about a pencil size to a dime size from your injection, depending on the amount of volume you're putting in there. And so for the frontalis muscle, if I'm using a precise toxin like Daxxify has a peptide that makes the tissue absorb quickly, and so it doesn't spread at all. And then Xeomin has a lot of human albumin. I mean, it has the most human albumin than any other toxin. And because that human albumin, boom, the body picks it up super quick as well. So with those, I tend to manually spread it out. So let's look at her face and how I would inject the different toxins, okay? If I was using Dysport, lift your eyebrows up, relax, I would probably do 1, 2, 3, 4, 5 injections with 2 Botox equivalent units of Dysport or 6 units of Dysport at each spots. If I was using Botox, I would probably do Botox or Jeuveau. I would probably do 12. I'd probably do 1, 2, 3, 4, 5, 6, because it doesn't quite, it's like an intermediate. It doesn't quite spread as good as Dysport, but it spreads a little bit more than Daxxify or Xeomin, okay? But if I was using Daxxify or Xeomin, eyebrows up, relax, I'm going to do 2 rows across because her forehead goes pretty high up. So I will measure about 2 centimeters above the eyebrow. So probably about right there, right there, right there, right there, right there. And then I'm going to do another row of 4 spots there. And I probably just put 1 unit at each of those spots. So 1, 2, 3, 4, 5, 6, 7, 8, 9 units in the forehead. That'd be a good starting dose for her. If I wanted to up it, then I'd probably do like 2, 4, 1, 2, 4. So that'd be 9, and then maybe like 2, 2 with another 4 would be about 13 units. So we could do something like that. But I'm going to want to inject in more spots with those precise toxins. Precise or non-precise toxins in the glabella or the procerus, it doesn't matter. I don't do multiple injections. So I just do my standard injections. Scal, the head, try to inject right into the head of the corrugator, and then in the tail of the corrugator. Relax, Scal. See how that tail right there is pulling down as well. If she wanted more of an eyebrow lift, I would also inject the orbicularis oculi right where the temporal fusion line comes down and meets the eyebrow. Right there's the magic spot. We'll inject that, and that will relax the depressor. The frontalis becomes dominant and lifts her eyebrow up. I wouldn't recommend that for her, but a lot of people as they age will tend to get like sagging skin, and they'll get a soft skin to their, or they'll start getting hooding of their eyes. And if they want their eyebrows opened up, always inject the orbicularis oculi right at the temporal fusion line. And that's a little 2 units right there. Boom, eyebrows come up, and will pull up with the frontalis will pull all those muscles up. So those are some little hacks on the forehead that we can do. Lateral canthal lines, big smile. You know, I pick the top one, I pick the bottom one, and then usually split the difference. Sometimes if there's a big gap, I might do 4 injection sites, usually about 2 units. Give me a big smile. So one of the things, relax. One of the things that you need to assess a patient is sometimes they'll get a line right through here, all right, from the smile action. Now she doesn't get that. Okay, so the risorus muscle pulling back the corner of the mouth pulls the skin tight, and they'll get a line right there. It's really important for you. It's really important for you to notice that line, because they'll think that you're going to turn that off with tox, and you're not going to be turning that off with tox, because that's the risorus muscle causing that. So if I see somebody smile and I see a line right there from the apple of the cheek, I'll let them know, hey, I'm not gonna be able to get rid of that line. The only way I could is to turn the risorus muscle off, and then you're not gonna be able to smile. And that's just not gonna go away. So having a little bit line that's low, you can inject that area in the orbicularis oculi, but that's not the muscle causing the problem. It's the risorus muscle and maybe some of the levitator muscles that are pulling up, causing that problem. So you might not be able to get rid of every lateral canthal line from injecting it. If it's, you got to identify the muscle that's causing the problem. So there's some lateral canthal lines treatments. Other muscles we can inject on the upper face, and we're actually more of the mid face is the nasalis muscle. Give me a bunny nose. Boom. Boom, right in there. You can also inject right down here underneath the nose, straight to the bone. There's a muscle that pulls down the nose. And if you turn that muscle off, the nose will kind of lift up a little bit and kind of give you a little more of a little pouty nose. I don't know what they call that, but you can lift the tip of the nose up a little bit as well. And so that's with tox as well. Lower face tox is one of my favorite things to do. We love hitting the depressor angularis ori. How do you find the DAO? You have them do a pout. So stick the bottom lip out like you're pouting, right? And then when you do that and go grr, when you say grr, right there. So yep, stick that bottom lip out, and you can really palpate that DAO right there, DAO right there. If you're having a hard time finding it, it's about a centimeter. If you draw a line straight down, midpoint about 1.5 centimeters over is about where that DAO is. Okay, so landmark, oral commissure straight down. If you go oral commissure straight down and go midpoint over about 1.5 centimeters, that's typically where the DAO is if you're having a hard time palpating it. Now you have to be careful with the DAO because you have the DLI right here. Smile with your teeth. That pulls down, relax. And so if you accidentally hit the DLI, what's going to happen is when they smile, that will not pull down and they'll have a crooked smile. Okay, and you just have to wait 3 months for that to go away. So be really careful not to hit the DLI. Other muscle that we can hit with her would be the mentalis muscle. Give me that pouty lip. You can really see that mentalis muscle pop out. I do 2 units, and then 2 units right there. It's kind of a triangular shaped muscle that's bifurcated. And so I'll hit each head and then the insertion point there underneath the lip. to turn that off. Okay. You can also do a lip flip if she wanted a little bit more volume on the top lip. It's not really a volumizing treatment. It just relaxes the orbicularis oculi, the orbicularis oris, to kind of roll that top lip up a little bit. All right. So those are definitely some lower tox treatments you can do. I always look at the jawline as well, and I see, okay, do we need to slim up the jaw? Sometimes people will grind at night, so clench your teeth, and that the masseter muscle will be kind of enlarged. I would say she has an average size masseter muscle, but you can make that masseter muscle go hypertrophic by putting some toxin in here. So 10 to 20 units of tox in each masseter muscle. If it's kind of bulging, that can be more of a masculine treat. And so we'll just inject the masseter muscle. Identifying the masseter muscle, we just draw, or where to inject, we just draw a line between the tragus and the oral commissure, and then we just try to stay below that line on the masseter muscle. So here would be where we injected. Okay, so that's a different muscle we can inject as well. Now, one of my favorite treatments to do, and I've been really doing a lot of these lately, is a Nefertiti Lift. Botox just got approved for the Nefertiti Lift, and the Botox protocol is you inject the platysma muscle. So the platysma muscle goes for the collarbone, it wraps the neck, and it comes up and over the jaw, and it kind of ends right here on the mandible. Okay, and so the bottom part of the mandible has a whole bunch of muscles coming down to it. You got the rhosaurus muscle coming right through here. You've got some the DLI coming right down through here, and you got that platysma coming up. The platysma muscle is a depressor on the lower face. All right, it is pulling down. So I want you to clench and flex your neck. Yeah, like this. There you go. Perfect. Okay, so that's the platysma muscle. You can also see platysma bands that pop up on her as well. So we could turn those bands off with a little bit of tox. The Botox protocol for platysma bands is different than I was trained, and I've actually been using it a lot, and it's been working really well. I was always taught with platysma bands, you find a band and you put up to 5 injections in that band, about a inch, 2 centimeters apart at each spot, and put about 2 units at each spot in the band. And that has always worked great for me. The Botox protocol focuses on the upper part, or the superior part of the platysma, focusing on that and then putting less medicine in each band. So let's use the Botox protocol, and I'll show you what the Botox protocol is. All right, so the Botox protocol is you inject the platysma muscle between the DLI and the, there's a little notch here, it escapes me what that's called, right here where the facial artery comes up and over the jawline, but you'll feel a little notch there. And so I identify that little notch. That notch is the medial aspect of the masseter muscle. It's also the lateral aspect of the platysma band that we want to inject. So I'll find that notch, I'll go right over to the right of it, and right at the angle of the jaw, I'll put 2, 4, 6, sometimes 8 units right in there, okay? And by doing that, you're relaxing the platysma, and a lot of these bands will go away with just that injection. And then what I'll do is I'll identify the platysma bands. Go ahead and do the neck thing, yep. And I'll say, okay, I'm gonna just do 1 unit, 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 okay, to get rid of the platysma bands on that side. All right, and then I'll do the same thing over here. Why do we want to focus our tox on the superior part of the platysma muscle? Is because it's pulling down all the facial muscles as well. And if we turn that off, we turn off the depressor, the levitators become dominant, and what ends up happening? Her whole lower face gets lifted. Okay, so we'll inject the DAO, we'll inject maybe 6 units on the platysma muscle, and then the levitators pull up, and it's akin to about a 0.5 cc of filler you would do in the cheeks. All right, so if you had a 0.5 cc of cheek filler, that's the equivalent of what a Nefertiti Lift will do for you. So tox is a great way of fighting gravity on the lower face. I started doing this about 2 years ago in my practice. Every single patient, with very few exceptions, absolutely loves that. It takes about 16 units to do a Nefertiti Lift. You do about 6 units over here, 6 units over here, that's 12, and then another 4 units on, or 2 units on each DAO. Boom, you can lift the face significantly. They look fresher, younger, and women absolutely love it. They have the platysma bands. Then after you do the Nefertiti lift, you can go in and you can put 1 unit at each spot on the platysma bands, and that has been working great for me. So there's a little Tox rundown on what you can do with facial anatomy on the muscles. Now let's switch it up a little bit and let's do talk a little bit about filler. What kind of different spots could we put filler to maximize her look? So let's go look back on her face. The first thing with filler we need to identify are the 6 spots where arteries come out of the skull. And those 6 spots are often, the easiest ones are on the mid-pupillary line. So if she looks straight ahead, so looks right here at my finger, and you bisect that pupil, that's where a lot of the arteries come out. So we've got the mentalis artery coming out right there. We have the infraorbital foramen. There's arteries and nerves that come out of there. And then we've got this I can't remember if this is supratrochlear or supraocular foramen right here where nerves and arteries are coming out. Just medial to that will be the supratrochlear, supraorbital. I can't remember which one's which. One of them supraorbital, one of them supratrochlear. But you have those 2 foramen right there where nerves and arteries come out. So there's 1, 2, 3, 4 spots on the face we don't want to be injecting. Where's the other spot? Right here, where that facial artery goes over the bone. So, and that part of the bone is where we want to avoid. So if you do jawline filler, you need to be using a cannula in this area. You do not put a needle there, because where do we want filler when we're building facial structure? On the bone. And if you put filler on the bone here, you also have an artery on the bone. Okay, so arteries are on the bone there, and there. And where's the last place an artery comes out on bone? The zygomatic artery, which is right in here. All right. There's no really identifying landmark for that, but just be really cautious of where that zygomatic artery comes in. All right. The facial artery comes up and over, and it's a tortuous artery that comes up, and there's branches of the inferior labial artery, superior labial artery. There's a nasalis artery, and these arteries cross the face. The right and left facial artery will actually have a nasinosis between them, and you can put filler in a facial artery here, and it could clog up over there somewhere. Okay, so don't assume because you're on the right side of the face that the left side is not going to be affected by a vascular occlusion if you do filler. Okay, so when I teach patients filler, or when I teach my trainees filler, I tell them filler needs to be in one of 2 places. It needs to be in subcutaneous space, and that subcutaneous space is either on the bone or just underneath the skin. Why subcutaneous space? Most of the arteries and nerves are in the muscle layer. Okay, and if we break the layers of the face down, we have skin, subcutaneous tissue, muscles, subcutaneous tissue, bone. Okay, so if I put filler on bone, I know that it's going to be right on the bottom layer of that subcutaneous tissue, right? It's going to be on the periosteum, and it's be between the periosteum and the subcutaneous tissue. Or if I go subdermal, I know I'm going to be in that layer. It's when your needle's deep and you don't know exactly where it's at, you're likely in the muscle layer, and that's where all the arteries and the veins are. So stay out of the muscle layer. So how do I know if I want to do a superficial filler? I'll pull my needle up, and if I can see it, I know I'm in the right plane. If I can't see it, I'm likely in muscles, and I don't want my filler going into muscles. All right. So avoid those 6 spots on each side of the face where the arteries are coming out of the skull, or where the arteries are on bone, and then inject deep onto periosteum or superficial into subcutaneous. So if I was going to highlight her cheekbone, I would draw a Hinderer's line, find the optimal point of light reflex, which is going to be right in there. And you find that by drawing Hinderer's lines, if you guys remember how to do that. And so there's the point of optimal reflex. And then I would probably just inject filler right on the bone, right through there. And as I'm getting close to that infraorbital foramen, which is usually right about there, I'm going to be very cautious that I'm not putting my needle into that infraorbital foramen. I'm going to be aspirating and things of that nature. So this is a no-go zone. Right medial to infraorbital foramen is that tortuous facial artery. So I tend to not like to put filler in this area. If I need a little volumization there, sometimes I'll put filler right on bone, right here where the nasolabial fold meets the nose. I'll go straight down into the bone, and I will put a dab of filler to kind of pop up this little area. If you're on bone, you're not on artery, right? So if I go straight down to the bone, I'll aspirate, make sure I'm not on artery. I'll put, 0.2 cc's of filler right there. That'll soften the marionette line. Also add a little bit of volume, kind of push the skin up a little bit if I needed some support there, okay? But I really try to avoid this area. This is a dangerous area. Other dangerous areas with arteries with filler is anywhere on the nose. This is a very, very, very dangerous place to inject. If you do it, only use a cannula, and even then you got to be really careful. And then the glabella is always a never-go zone. I never put filler in here. Why? The skin layer to the bone, there's only 4 millimeters of distance, okay? And what did I already tell you? You want to be on bone or subdermal, okay? There's only 1 millimeter of give in there. So your needle has to be precisely in that one plane. And if you're not, you're likely a muscle and you're going to be right in an artery. And this has a high propensity, the glabella has a high propensity for vascular occlusion. So don't ever put filler in the glabella. It's malpractice. Nothing's approved FDA. If you do it and you cause a vascular occlusion, it's going to be on you to do it. So don't do glabella on filler. Okay. What my favorite thing to do with filler, other than lips, because lips are kind of a standalone, is to put filler on the cheekbones. With almost any situation, it will make it look better. And how do you identify if they really need filler? Is you have them look straight ahead and you line up the tip of the nose to the opposite cheek. And when you line up the tip of the nose to the opposite cheek, that shows you the OG curve. Okay, and we want a nice prominent OG curve. And hers is a little bit flat, and so adding a little bit of volume there would help pop out that OG curve and give her a little bit more femininity to her face. So I like the idea of putting a little bit of filler here on her cheekbones. I think we've done that for you in the past, haven't we? Yeah. She's probably due for another round. What kind of filler would we put there? A high G prime filler, like an RHA4. Radiesse is one of my favorite things to put in there as well. That biostimulator is a nice thick filler. You go in there, you get immediate results with Radiesse in the filling, and then you get that long-lasting growth of collagen and from the fibroblast stimulation as well. So Radiesse is great for the cheekbones as well. Radiesse is horrible for subcutaneous fat. Okay, we do not want to put Radiesse on fat. It always goes straight on bone. Okay, now if you dilute it down, you can use Radiesse as a biostimulator somewhere, and everybody could use Radiesse as biostimulation. So if you don't have Radiesse in your practice, get it, you dilute it down like a 1-to-1 or a 1-to-2 or a 1-to-3, meaning you dilute it down 3 times, and then it can flow in and be a biostimulator. So if you're not doing like microneedling, let's say you have a mobile practice, you don't want to do microneedling, but you want to get some collagenesis, give them a Radiesse treatment, okay? Dilute it down, use a cannula, flood the whole face, the neck with Radiesse, and it is a great, great, great thing. You can also use Sculptra as well. I like Radiesse better. You get more elastin production with Radiesse and Sculptra doesn't do much with the elastin. So that's another thing you can do. So other areas we could do filler, obviously we could do lip filler, nasolabial fold. She doesn't have any marionette lines yet, but we could do a little bit of filler in there as well. But I would say most filler I do is lip filler, followed by cheek filler, and then probably followed by jawline filler. I try to stay away from nasolabial folds or marionette lines because I can usually put filler underneath the face and hit those spots, okay? So that's face filler. Those are the most common places for filler as well. And there's lots of courses out there that I don't teach that you should look into, like a 13-point injection technique from like the Injector Bunny. She has 13 key points that she injects on the face with a couple cc's of filler that kind of gives you a nice good pop. So you can check out her course or her Patreon account on how to do that as well. Another place you could put filler that a lot of women could use it is you could do a biostimulation filler like Radiesse on the back of the hands. Now she doesn't have it yet, but the hands will age very quickly, especially as she gets closer to menopause. So I always say the face, hands, and neck are what's going to show you your age. And you can dilute down some Radiesse and just flow it on the back of the hand and get a good biostimulation, especially for like older women like in their 60s and 70s that have that really thin pasty skin on the back of their hands. It's a great treatment to do. It's actually FDA approved to treat the hands as well. So anyways, that's a real quick and dirty anatomical breakdown on how you can use toxin fillers in your practice. It's not by any sense of the word, a all-encompassing course, but take a good anatomy course. If you ever have an opportunity to go do a cadaver course, that's really, really fun as well. I've done a couple of those where you can actually see where your needle's going or your cannula is going as well. So check out those if you have one coming into town. And if I hear of any, I'll post it for our members as well. So anywho, that's a quick breakdown. Hope you learned a few things. Now go incorporate some of those things into your practice.